And welcome back, everyone, to our series where we interview people from the hepatitis community. My name is Carrie, and I'm back with Daryl for part 2 of our interview with Nance Cunningham, a PhD student at the University of British Columbia. So if you haven't heard part 1, now is a good time to go and do that. And we're just going to jump back in for part 2 right now.
Can you tell us some more about your work now?
I agree. There's a really good opportunity to do microelimination here in British Columbia as well. And there's already a group in Victoria, the Kool-Aid Society, that has done a microelimination program that I heard about already last year. And I hope that there will be more, because really right now I think community by community is the way to accomplish elimination in British Columbia. And that's partly because you need to reach the people who need to be treated. And you can't do that with a mass campaign. You really need to understand each community and talk to people individually and understand who is at risk and make sure that they trust you enough. And only then are you really going to be able to reach everyone who you need to reach and to eliminate hepatitis C in British Columbia and in Canada. Because of course there's a goal to eliminate hepatitis C as a public health problem in Canada by 2030. And that's actually starting to look really close.
Yeah.
So as for my work now, I am just at a stage where I am starting out on a 4-stage research program, which starts out doing quantitative research to understand whether people who are in priority populations for hepatitis C, so these are the people who need to be tested and treated first, whether they have less healthcare engagement than the general population, and if I can measure that. And then I do another stage of qualitative research where I talk to people in different priority populations to understand their experiences in the healthcare system. And then I talk to people in the healthcare system to understand their perceptions of the priority populations and their understandings of what barriers they have to providing care. And then I bring it all together with the barriers that the people who need the treatment are experiencing, the barriers that the people who are giving treatment are experiencing, over this background of being able to see literally in the numbers how people are not getting the treatment that they need and not having the health outcomes that they deserve. And I put that together into training modules so that people who are providing healthcare services, and that's not only doctors and nurses, I'm also talking about pharmacists, receptionists, everyone who is involved in the healthcare system who has contact with hepatitis C patients and who the people who are at risk for hepatitis C might have had poor experiences with. I create educational materials for all of these different groups that tell them how these priority population members wish that their healthcare encounters had gone if they've had bad experiences. I put that all together into these education modules, and then I put them in practice and then measure whether people's comfort, whether the healthcare providers' comfort with working with people in these priority populations has changed after they've had that educational experience. That's my goal.
Awesome. That's great, because I mean, it speaks to, I think, what most importantly that you've learned from the community and from the general experiences of people that you're able to summarize into kind of a big picture that will help provide better care at the end of the day, at the end of the project. I certainly think that in past conversations that we've had both in this series and the Hep C 101 series is just like using information from actual people explaining what would have been helpful for them and what they would want or what would have made their experience better. The only way you're going to get that information is from talking to people, and it's great that we will eventually be able to use your work in helping to give people a bit more guidance in framing their interactions.
Yeah, exactly. It's like I said before, people go into the healthcare work because they are really good, compassionate people who want to cure people of, want to relieve people's pain, want to cure people of their problems. But then, as we know, day-to-day work is different from, from your ideal work, isn't it, sometimes? And so I think you really have to understand both sides to find out, like, what are why people have been resistant to giving the full treatment that people with hepatitis C deserve. And then also, like you say, just ask the people with hepatitis C, what have their experiences been? And yeah, really, it's just a matter of doing a lot of listening and then figuring out how to combine the quantitative research that will show that. I think the quantitative research is also important because you have to show that there's a difference, right? Like, I think to all three of us, it makes logical sense that have people having been stigmatized ever in the healthcare system will discourage them from going back for treatment. But, in fact, it's really helpful to be able to measure things like that. And then to be able to see whether this intervention of giving education is really an effective way of changing those outcomes. And if it isn't, then you have to go back and find out, then you have to realize that, okay, this was not the barrier that I thought it was, or this was a barrier. I've removed this barrier, but there's another barrier after it that now needs to be worked on. And that's kind of what we've seen already, right? Like, the first barrier was that only people with comorbidities or with, like, poor liver scores were able to access the treatment. And then once you remove that barrier, it reveals that there's this other barrier, stigma, which is still preventing people from getting treatment.
Do you think there are that most of these issues live in or reside in the failure of systems? I mean, is that what I'm hearing? Is it systems around educating healthcare providers, or can you elaborate on that a bit?
It's yeah, I'd like to be able to answer that question, but I can't really answer it positively yet. And that's because I haven't started doing that research yet. I've talked to healthcare providers. I've talked to nurses, I've talking to nursing students, I've talked to phlebotomists, I've talked to as many people as I can, just kind of informally, but I haven't formally started that research yet. And it's really only when I think, systematically talked in depth to a wide variety of healthcare professionals and also to students, and also talk to people who are creating the curriculum and to people who are lecturing in that curriculum, and find out how they're teaching about stigma, or how they think they're teaching about stigma. Or, as I actually prefer to phrase it, I actually like to focus not on stigma, but on respect, because that's what we're going for, right? You need to have respectful interactions in every single healthcare encounter. And I'm sure that this is being taught in the schools. I've talked to students about how it's taught to them, but I don't know how the lecturers think that they're teaching it. And that's what I need to find out before I can really answer that question. I certainly think that it's a possibility because, like I say, I am sure that these healthcare professionals are going in there with the best of intentions, and it's just not working out according to their intentions.
Well, that's why I ask about the system. Is it the system that they're then going on to be part of that's at fault, or, yeah?
Well, I'm hoping that it is, because that's the level that I can make an intervention on. I can't go around and, like, take every person to a couple of therapy sessions and work out why they're stigmatizing patients. I'm hoping that it's a systematic issue, and that providing educators materials that they can use in every kind of level of health education, and also providing continuing professional development courses so that people who are just about to start treating hepatitis C patients can also get advice directly, essentially directly from previous hepatitis C patients about how they would like to be treated, about how to address them, what problems they're likely to have, what background they have that's going to make them sensitive to certain comments, and to just make everybody comfortable in that interaction. So then the healthcare provider knows a little bit, has a little bit of advice about what previous problems their patient might have had. And then the patient, hopefully at some point, will have had more good encounters with healthcare professionals and will also be more comfortable in that setting. And that's how you're going to get the best healthcare and the best outcomes.
Would you like to share some closing thoughts with us, Nance?
I have so many closing thoughts because I'm really just starting out on my research journey here, and I've got a lot of really hopes for understanding what the situation is in British Columbia for people who are, who should be being treated for hepatitis C, for the people who should be treating them. But really, my biggest thing is that I'm so happy to be able to be part of the campaign to eliminate hepatitis C in Canada. I don't know if it'll really be by 2030, because like I say, that's looking awfully close. But really, I think if we really band together and everyone is serious about it, and the amount of resources that it really deserves are thrown into it, I really think that we can do it. We can eliminate hepatitis C in this short period of time. And then after that, it'll be so much easier to just deal with the individual cases that turn up from time to time. And actually, it'll be a massive burden that's removed from the healthcare system after that, and removed basically forever. So I'm really happy to be part of that. And if not by 2030, we'll get it done sometime fairly soon.
Thanks, Nancy.
Thank you so much for coming in and talking about all of this with us today. I think I certainly have really enjoyed getting to hear about your work over the past 8 months, 10 months, something like that. And I'm really excited to continue to follow the work that you're doing and continue to engage with you as we move forward with our own microelimination type projects with Pacific Hep C. And I'm sure Daryl has something to add about this in the context of our Screening and Linking into Care project.
Yeah, we're certainly looking to get on the road again, as I mentioned, and reach some more sites. Of course, in this COVID era, it presents some additional challenges for us, but healthcare continues. Certainly, people are still sick with other things, and there is much to be done. And like you say, we may not reach elimination by 2030, but we're sure going to try. We're going to work as hard as we can. And it's sure great to have you as part of the overall team, Nancy. It really is a pleasure, and has been a pleasure working with you, and will continue to, I'm sure. Thanks.
Yeah, well, thank you. I've really enjoyed what I've done with Pacific Hepatitis C Network, and I think that you guys are doing really great work, and I'm so happy and proud to be a part of it.
Thanks, Nancy.
Thank you so much. Learn more about viral hepatitis and the BC Hepatitis Network by visiting bchep.org and contact us at podcasts@bchep.org. You can also find us on social media via the links in the show notes. For more episodes, visit bchep.org/podcasts or subscribe on YouTube or your favorite podcast app.